Well, for a long time, this was the question, aren't you better off just treating the borderline patient by yourself? Because if you add another treatment arm, the treaters are likely to be split by the mischievous, troubling patients that borderline patients will cause splits. And it's true that when you have split treatments, multiple modalities working concurrently, it is possible for the clinicians to have different perspectives, give different messages, and end up being hostile towards each other in ways which are damaging to patients. That is not something which should be attributed to the patients, however. That has to do inherently with the lack of communications, lack of definitions of the roles that clinicians have, lack of respect or appreciation for what the other modality is providing. The advantages are that when you do have more than one modality, compliance with treatment is enhanced. Patient gets angry at one treater doesn't mean that they acted out by discontinuing the other treatment. And they go to the other treater with their complaints, and that helps them be a buffer that gets them to process the difficulties they're having with the other treater. It also decreases the burden on the treaters. So if you feel overly responsible about something like safety or coverage when you're away or things like this, it's nice to have another treater. It's a built-in safety valve for anything related to litigation. When the treaters collaborate. Rules for split treatment, you have clear roles, especially with regard to managing safety and communications with families. You don't enter into a split treatment where, for instance, your patient agrees that they will see a psychiatrist who will manage their meds, but you can't talk to them unless they give you permission. Or they're going to go to talk with the family therapist, but that has to be kept, what they have to say is confidential, and that the family therapist can't talk to the parents about it. I mean, confidentiality is a big bugaboo, and once again, it starts with us. There's nothing in the laws governing mental health that suggests that you can't insist on the right to talk to other treaters. It's just upfront. If you agree to confidentiality and then you don't do it, then you might have problems. But even then, that would never happen if any issues having to do with safety are involved. So have your head on right. And again, sometimes our educational system so prepares clinicians to worry about the bad things that can happen that they don't use common sense to govern their practices around confidentiality. If you're doing a split treatment, it only makes sense to do it if the treaters can talk to each other. So that's just upfront. Of course we will. You can assure the patient you'll use discretion. You're not going to go talking to the other treater about anything and everything that they say to you. Some matters are only germane to what goes on in the individual therapy. But anything having to do with changing the treatment, anything that has to do with safety, anything that has to do with planning for forthcoming vacations, or of course you will. Non-negotiable. The single most cost-effective additional treatment that you can give for borderline patients is group therapies. I urge any and all of you who work within clinics or any kind of institutional setting or any kind of group practice that you not accept borderline patients into that practice without or unless they are in groups. Groups do things that individual therapies can't. Borderline patients will rarely volunteer to be in them. And when Marcia Linehan said in 1990 or whenever she started DBT that it's a package. You got the group and the individual therapy. I was amongst those who was just thunderstruck because for 15 years I'd been listening to borderline patients say, I don't do groups. I won't, you can't put me in a group. I don't like groups. I can't stand groups, and I won't do it. Oh, okay. And, besides, I like doing individual therapy better anyway. But, once it got through my thick skull that, you don't have to make this an option, and that it was clear that the benefits from groups were quite different than what people got out of individual therapy. And indeed, individual therapy in the absence of groups is a limited tool. That, of course, you should do this. So whenever it's possible to enforce it, you should do it. Now, you can't do that when you're in office practice in a rural setting, or there's many places where it's very difficult to find a group for the borderline patient to enter. But where it's possible, it's always good, very cost beneficial. It does things that you can't do. There's a couple of recent studies. I think I have a slide. Yeah. Here's a more theoretical statement that Peter Fonagy has made at a conference we did together recently. But in the background of that is this study published by Linehan this year, where she separated out the group component of DBT from the individual therapy component. And what she found is that if you have the group component with a PRN case management, it did just about as well as standard DBT, the group and individual. Take the individual component of DBT and put it with a sort of expressive group, it did not do well at all compared with either of the other two conditions. And this study, somebody told me last night at dinner that this wasn't a very good study, but it nonetheless illustrates the same thing with respect to mentalization-based treatment, that it was the group therapy that is carrying the weight. And that's sort of my clinical impression, and I'm moving in that direction. But quite aside from what's better than another, group therapies are very powerful with borderline patients. They're very cost beneficial. Any of us who work in public health care settings owe it to patients and to taxpayers in our district to make sure the borderline patient gets their group. The individual therapy, I call it the dessert course in our outpatient clinic. That's what you get for being a good patient, not because it's what's good for you. It's what you like. Going back, here's what groups add. Any questions about that? Scratch the top. You got me tempted there. You're teasing me. Year. Okay. Few minutes. Oh, you got a question, comment?
Yeah, well, just a little comment. In Norway, there's the group therapy is a huge activity in all of the country. So there's fantastic probability, vad heter det? Muligheter? Probabilities to
Yeah.
use it. So
Yes, yes.
I think
Good.
there's lots of people here. You're doing groups with borderlines, but perhaps you don't have any questions about it because
that's
you
good.
manage it so well.
No, but I'm reassured by that.
Yeah.
In the United States, for a long time, there's been such an emphasis on individual therapies,
yeah.
and that they have there's been inadequate attention to the value of other therapies and group therapy. It's ironic and interesting that in my outpatient clinic, where when we started insisting on it being required for patients, the clinicians then said, well, I don't do group therapies. Nobody taught me to do group therapies, or I don't like group therapies. Now, they all love doing group therapies. They find them more interesting and less burdensome than the individual therapies or the family therapies. Different kinds. There's different kinds of. Somebody asked me during the break about what kinds of groups are best for borderline patients. I would say any group is better than no group. That some groups are more demanding than others. So this is sort of a hierarchy in our outpatient clinic of how we assign patients to various groups in terms of how difficult they are. Family interventions. Yes, right over here.
I have a question. I'm going a bit back in your talk. I work in a group. We are doing group therapy with borderline personality and others. And you were in the beginning. You were saying that you don't use intensive therapy any longer. You want it more simple, and I wonder. We have a good experience with intensive programs, like 2-3 times a week, and I wonder, do you have any opinion on that?
We use the clinical programs that I oversee at McLean Hospital are both quite intensive. The GPM model of treatment is really designed for people who do not work in situations where intensive treatments are an option. And the message is that you can do a lot of good without a whole lot of resource utilization, and that intensive treatments should be reserved for those who cannot do well with less intensive treatments. When you get into intensive treatments, they're much more expensive and they require much more coordination amongst the team members. So by no means would I say they're not effective, but they should be reserved for the people who have failed in non-intensive treatments, that's all. Let me say something about family interventions and then we'll stop. You'll see some familiar themes here. Psychoeducation for families is very important in terms of building alliance, cutting down intra-family conflict. Involvement by families, soliciting and getting their active support for treatment is oftentimes necessary for the offspring to be treated. Sometimes it's sufficient if you get a strong working alliance with the family, you can change the family environment, which is sufficient even by itself to make major changes in the borderline patient's life who themselves refuses to be in active treatment. There are a hierarchy of family interventions. Everybody should have the psychoeducation. This is a family guidelines that was published by National Institute of Mental Health, now available through the New York City Resource Center for BPD. If it has never been translated into Norwegian, it's a very good tool for people to have in their offices and to give families. Tell them to put it under their pillow or on their refrigerator door. It's guidelines about what to do, what not to do, things like this. They're just common sense. But families oftentimes are so grateful for whatever help you can give them. You build an alliance with them very quickly if you see yourself as somebody who is exposed to their troublesome son or daughter a few hours a week, whereas they oftentimes are exposed to and feel the responsibility for 24/7 and have for many years. They are oftentimes beaten down by this responsibility, and they need to be supported and instructed about how to revamp the home situation in ways which is constructive as opposed to destructive. Parents almost never do anything willfully bad for their kid. They may fight with you when you tell them to stop doing something, but they generally can't shake off the idea, the knowledge, that their kid has gotten ill under their watch and that they probably could and should learn new ways to cope with this problem. So even very resistant families generally will come around by their underlying insecurities about what they have done or what they don't know. And it starts with psychoeducation and your ability to identify with them. Should we end up now? Yeah. So let me end by saying that borderline patients don't usually say, well, let's set aside the next couple of months to say goodbye to each other, remember what's happened here, and the good times and the bad times. That model of mourning that I was taught when I was doing my residency is the way therapies end. It doesn't end that way. I don't know whether it ends that way with anybody, but certainly with borderline patients, what happens is that gradually life takes over. They have other things to do that conflict with their schedule. They have other supports that they can depend on rather than those that they get out of treatment. They have their acute symptoms are gone and they've settled into something that may not be healthy, but which is satisfactory. You become sort of obsolete. The internalization of soothing others, which addresses their basic intolerance of aloneness problems, takes years. It may happen with you. More often, it's going to happen with people, new relationships they form outside of treatment. The good partners for borderline patients, as you might predict, are those people who are stable, solid, unemotional, dutiful, and that's the best partner for a borderline patient, no matter what they tell you. So you can let them know about that too. So why do this work? You're capable of it, most of you. The mental health professions owe it to these patients. It's a major public health problem which is not sufficient to turn our back on, that we don't know how to, or we don't like these patients, or that the untruths that they are either untreatable or intractable. When you know what you've learned today, then the burden's on you to take it on, individually and institutionally, training programs. You can then take pride in your skills. There's no question that in the working with these patients, you'll learn to be a better therapist in general. Some people say if you can treat borderlines, you can treat anybody, and maybe that's true. It certainly involves personal growth. You can't treat these people without personal involvement. And you can have a highly personal relationship which can change a person's life. And when we start out going into the mental health professions, that was oftentimes sort of the bottom line, the thing that we hoped most for, that this would be the role that we would have. And these are wonderful people to work with from that point of view. And they'll come back and say thank you. And sometimes they'll even say, you saved my life. Wow. So, thank you.